form. And we'd like to have the PGs know everything about how to deal with these children. So we'll start with the case presentation. I'll just on my slides. I hope you can see my slides. Uh-huh. It's not becoming full, huh?
It is. No. Slideshow.
Yeah. Okay, so this is our topic today. Severe acute malnutrition. Visiting differently. That's the question that we're going to ask, and that we needed a lot of awareness and a high index of suspicion for making a diagnosis. And the slide is not moving.
Try some other key, right key, left key, down key.
Yeah, so we'll start today's session as usual with the case presentation, and we'll start with Dr. Shija Sugunan to give the details of this case. Dr. Shija Sugunan, I think most of you will know her. She's a very good speaker. She is the Associate Professor of Pediatrics at SIT Government Medical College, Trivandrum. She was a graduate from Alleppey and did her post-graduation at Trivandrum and a fellowship in the Pediatric Intensive Care at Mehta Children's, Chennai. Authored a book on immunization, and I'm sure most of you have seen this book. It's an instructor for PALS, TIPS, SOS, HOPE, etc. She's a speaker in many national and international conferences and has published multiple papers in national and international journals and contributed to various pediatric textbooks. Over to you, Dr. Shija.
So good evening, everybody. First of all, I thank the IAP Cochin branch for giving me this opportunity, and especially Dr. Jason Siuni, who has really been working behind the screen to make this venture happen. So coming to my job, that is, I'll be taking you through the next 15 minutes, a journey of a 5-month-old baby. So this was a 5-month-old baby who presented with fever and loose stools of 6 days duration and skin rashes of 6 weeks duration. So young infant having a little long history. So I'll start it from the birth. The baby was firstborn child of non-consanguineous parents belonging to upper middle class family. The mother had an uneventful antenatal period with regular antenatal checkup, iron and folic acid supplementation with a 13 kg weight gain during the pregnancy. The baby was born full term with a birth weight of 3.5 kg. The baby had cried soon after birth. There was a normal antenatal and postnatal history and put to breast soon after birth with no prelacteal feeds. She was exclusively breastfed till 2 months of age. And the mother remembers the weight, that is at 6 weeks when they had taken the baby for the first vaccination, the baby was 4.5 kg. So had gained 1 kg in the 45 days. But at 2 months of age, the mother had a breast abscess for which she required an IND, and she was advised to stop breastfeeding after that. And following stoppage of breastfeeding, the mother had started the baby on formula feeds. She was trying to match the consistency of the formula with the breast milk, and that's why she was adding 1 teaspoon formula to half a glass of water. By 3 months of age, she started complementary feeds with dilute ragi, and which was also given through the bottle. Meanwhile, at 3.5 months of age, the child started developing erythematous skin rashes, which later became hyperpigmented, especially in the intertriginous areas and outer aspects of the arm, which progressed to peeling, exposing dry underlying skin. The baby was initially taken to a homeo doctor and later to an Ayurvedic physician. But as the skin lesions progressed, and it involved the whole body with dyspigmentation, fissuring, and underlying wet lesions, this time the patient was shown to a dermatologist and presently under the treatment of a dermatologist with a diagnosis of infantile psoriasis. And the present history, the child is having fever and loose stools of 6 days. There is no blood in stool. Baby is passing large volume watery stools 6 to 8 times per day. And after the starting of diarrhea, the mother is now giving dilute ragi and arrowroot powder porridge. And for the last 24 hours, the urine output is less. The last urine was passed 8 hours back. And the child, on the day the child was brought, the child's intake was poor. Child was refusing feeds and also had become increasingly lethargic. Past medical history, there's a history of loose stools at 4 months of age. It lasted for 3 days and subsided of its own. There is no history of recurrent vomiting or any abnormal color or consistency of stool in the past, apart from the 2 diarrhea episodes. There's no history of any vaccine-preventable disease, especially measles and pertussis, and also no history suggestive of chronic or recurrent respiratory, cardiac, or renal disease. Developmental history, the child had attained all milestones normally till 3 months of age, social smile at 6 weeks with neck holding at 3 months and was cooing at 3 months. But after the skin rashes developed, the child's activity had decreased. And now at 5 months of age, the child is not reaching out. There is no bidextrous grasp, even though the child grasps object which is placed on his hand. There is no laughing loud and no cooing also, no. And child is presently getting 280 calories and 2 grams of protein against an expected intake of 550 calories and 7 grams of protein. Child is immunized for age according to the national immunization schedule. The BCG scar is present. No add-on vaccines or optional vaccines have been taken. Family history has already been mentioned. The father at the time of conception was 28 years old and the mother 23 years. There is no history of neonatal, early infancy, or young adult death in the family. No history suggestive of tuberculosis, immunodeficiency, or any skeletal deformities in the family. And the family belongs to an upper middle class. General examination, the child looks irritable as well as apathetic with a pulse rate of 128 per minute, respiratory rate 38 per minute, CFT is 3 seconds, BP 80 systolic, with a temperature of 36 degrees centigrade in the axilla. Child appears pale, there is pallor, there's generalized edema, which is both bilateral pitting pedal as well as pitting presacral edema is there. There's no cyanosis, clubbing, or lymph node enlargement. Anthropometry, the weight is 6 kg with a length of 61 centimeter and the weight for height of 6 kg and a head circumference of 43 centimeters. When you chart it in the Z-score, you realize that the weight is between -1 and -2 standard deviation. The next slide, the length is between 0 and -2 standard deviation and the weight for height is normal. That is almost at 0 standard deviation. So taking into account, so from the anthropometry, the baby is not having undernutrition, stunting, or wasting. But when you chart the baby's growth chart, because the mother clearly remembers the weight that has been taken during the 6 weeks, 10 weeks, and 14 weeks vaccination. Next slide, you realize that the baby's growth has faltered towards the last 2 months. So initially it was growing well, and last 2 months the weight has faltered, even though the absolute numbers don't show great abnormality, but the growth chart definitely shows a significant abnormality. Next, head to foot examination. The head appears normal in shape. The hair is sparse and lusterless and hypopigmented, especially at the roots. Anterior fontanelle 2.5 into 2.5 centimeter, but AF is depressed. The face appears, there is a mooning of the face. The eyes are normal. There is no cirrhosis or Bitot spots. Tears are absent. Lips are red in color with angular stomatitis. Next, and the skin, there is a, next slide. The skin is showing a generalized patchy hyperpigmented rash with exfoliation revealing both dry and wet underlying areas. The skin over the chest and abdomen is especially cracked and hyperpigmented, showing a flaky paint-like dermatosis, whereas the skin over the extremities are showing peeling with underlying dry areas, while in the intertriginous areas, the underlying skin is wet and erythematous as well as oozing. Coming to the GIT, it is the lips are red in color with angular stomatitis. There is oral thrush. The tongue is red in color with no papillae. There is no bleeding gums or ulcers. The abdomen is distended with a liver of 5 centimeter below the right coastal margin and a span of 8 centimeter, and ascites. External genitalia as well as anal orifices are normal. So to summarize, it was a 5-month-old baby, firstborn child of non-consanguineous marriage with a birth weight of 3.5 kg with a normal antenatal, natal and postnatal history, exclusively breastfed till the first 2 months of age, then going in for a secondary lactation failure due to an abscess in the breast, leading on to faulty feeding. There is a history of 1 previous episode of diarrhea, and now presented with skin lesions of 6 weeks duration and loose stools with features of dehydration. There is developmental arrest after 3 months of age. Examination revealing an apathetic child with generalized edema, hepatomegaly, multiple overt micronutrient deficiencies, ascites, severe nutritional dermatosis, and hair changes with a grossly normal anthropometry. Now over to Elizabeth,
Thank
madam.
you, Dr. Shija, for that presentation. So we'll now have Dr. K. Elizabeth, whom you all know, to detail what would be the differential diagnosis in this child, the presenting symptoms of these children, and the clinical findings. And she's going to talk about that issue. Dr. Elizabeth, to introduce her, would be a huge list of things to talk about. But she's the professor of NHOD of Pediatrics at Sri Mugambiga Institute of Medical Sciences at Kulaksheram in Kanyakumari district. She was the state president of the Kerala state branch of IAP at 2016, the national president of nutrition chapter of IAP 2017 and 18, the advisory board of the Bioaccident International 2018 to 2020, and a fellow of IAP, fellow of the Royal College also. So she was the professor and head of department of SAT Hospital, Trivandrum, and she's got the Best Doctor Award, Lord of Orations, Honors, Awards, and publications to her credit. I introduce to you Dr. Elizabeth for her presentation. Unmute.
Yeah. Thank you, Dr. Jason. I think this episodes are really exciting, and I am coming for the second time. Thank you for inviting me again. I am very honored to be part of this. So Dr. Shija has painted one infant in front of us, and we know similar babies we are seeing. See, I am showing on the right side a baby who is having skin changes, hair changes, diarrhea. And on the left side also there is a child with skin changes, hair changes, and diarrhea. But you can see that the child on the right side died some hours after admission, whereas the other child on the left side could go home on some skin cream and some multivitamins. So next, press. So these two infants have skin changes. And in the case that Dr. Shija presented also, anthropometry seems to be normal, except if you have the growth chart, if you track the growth, you can know that there is a flat curve coming up. And the weight is with edema also. So we know that the first child is having acrodermatitis enteropathica. The mutation analysis can prove it. So when we have an infant like this, or a child with skin changes as the presenting complaints, we will have to think of differential diagnosis for the skin changes. That's why I'm putting this here. So acrodermatitis will respond to zinc, and sometimes spontaneous remission can also occur. See the right side, I'm again showing another baby. I had 2-3 babies like this, exclusively breastfed, less than 6-month-old. So much of skin lesions with oozing. They belong to one group of conditions called skin changes and hypoalbuminemia. Anthropometry was fairly normal or slightly faltering. So these are erythroderma desquamatum, that is Lehner's disease. Next. So babies with seborrheic dermatitis, recurrent diarrhea, can have some amount of failure to thrive, hypoalbuminemia. But if you look at the other things, that may not fit into may not fit into a SAM case, and this is flaky pain dermatosis. Yes, next. Now we call it as nutritional dermatosis. See, this infant is having seborrhea, alopecia, eczematoid dermatitis, hypotonia and convulsion. Again, this is another differential diagnosis. This is biotinidase deficiency. It is again a genetic disorder, inability to recycle biotin, and you know, raw egg has an anti-nutrient to it. And so this may end up with the neurologist sometimes. And who is this lady? She was in highlight recently, and she developed a type of a skin rash, and unfortunately she died. The keto diet. They call it the prurigo pigmentosa. It is said that there is a report of one man and one woman who developed skin rashes, the keto rashes, and they say that when the carbs were introduced, the skin lesions healed. The thing is that when you are totally cutting down the carbs, the yeast and the bacteria can invade you. And look here, previously Jelliffe and later on Grover has put so many findings in malnutrition, mooning of face. So whatever, Cushingoid, so that can come as a differential diagnosis. When they have eye changes, we can have differential diagnosis for that. And our patient had most of these. So we can think of a lot of differential diagnosis based on the clinical manifestations. Next slide. And we know that the hair changes are due to protein deficiency and multiple micronutrients, the facial changes and the chelosis, everything, riboflavin and multiple nutrients, the eye changes, again, anemia, iron, folate, B12, B6, vitamin A, then the tongue, riboflavin and iron again, the teeth changes are due to the calcium, vitamin D. Then they can have bleeding, that may be due to vitamin C. So we can think of every finding there is a micronutrient deficiency. That is why nowadays we don't prefer the term protein energy malnutrition, because the micronutrient malnutrition is quite significant, and by giving protein and energy, we are not able to cure this child. Next slide. So other differential diagnosis, if we think, we can also think of differential diagnosis of edema, renal causes, a hidden renal cause, a hidden hepatic cause, a hidden cardiac cause we can think of. I retrieved one patient, one doctor's sister's baby, an infant came with edema. And we were so wondering how will we diagnose kwashiorkor in this case. And the grandparents who were teachers were looking after this baby, and the mother got an appointment in North Kerala, and she left the baby with the grandparents, but they were naturopath. They were believing in naturopathy, and they were giving only coconut milk and the juice of the plantain stem. So finally, we had to diagnose kwashiorkor in that child. That child was admitted telling it may be Indian childhood cirrhosis. So there are a lot of differential diagnoses. That is what I want to tell you. But short stature will not come as a differential diagnosis, because only stunting will be there. And if wasting is there, then it becomes a differential diagnosis. Next. So I am telling you that you should have a checklist with you. Do anthropometry in detail. As Dr. Sheija said, try to track the growth monitoring also. Then only it will come. Then we have to do relevant biochemical and lab tests. Go look for clinical features. Take a very good dietary history. Here, the IYCF practices had collapsed. No, I was wondering breast abscess would have come only on one side. She could have continued the breastfeeding from the other side, but wrong advices came. Then environmental factors are there. Poor hygiene, socioeconomic factors, all those things will come. Functional, what is the functional impact on this baby? What happened to this baby? The smile went down, the milestones regressed or got arrested. So vitamin A deficiency means we know that night blindness will come, bony changes will come, growth arrest will come, bone age will get retarded. So, and growth monitoring. So if you please have a checklist with you and try to do. In the first child I showed, acrodermatitis enteropathic. His anthropometry was normal. Biochemistry was normal, except zinc. His clinical features, rest of the skin had very nice texture and it was good. Dietary was normal. Everything was normal except for that. Now, malnutrition, we know, has got it is a spectrum of disease with infection and lot of immunodeficiency. And the term that we prefer is nutritionally acquired immunodeficiency syndrome, NAIDS. And 54% of all the deaths are thought to be due to malnutrition. And what happens to the immunity? Breakdown of skin and mucous membrane, we saw in our case. Then lysozymes, macrophages, the killer cells, everything gone. Phagocytes gone. Complements reduced. Cytokine production is now dysregulated. Secretory immunoglobulin A is not there, and immunoglobulins towards the end also get reduced. Cell-mediated immunity is gone. Next slide. So what we can see is that our defenses get affected in malnutrition. Next slide. And there is an altered SIRS and CAS ratio. I think the postgraduates know what is the SIRS and CAS. That is, I will come to in the next slide. So the cytokines in immunity behave little abnormal. They are divided into two parts, the pro-inflammatory like IL-1 beta, IL-6, IL-8, etc. and anti-inflammatory, that is IL-4, IL-10, etc. interleukins. So there should be a balance. When you give omega-6 fatty acids, the pro-inflammatory gets upper hand. When you give omega-3, the anti-inflammatory may get an upper hand. We should have a balance. So that is why I said that goes into dysregulation. Yes. So the SIRS is the systemic inflammatory cytokine response. It should be balanced by the compensatory anti-inflammatory response or the CAS. So certain nutrients are good for the pro-inflammatory, certain nutrients are good for the anti-inflammatory. Next slide. And we can see that the NAIDS, the term also is something similar to acquired immunodeficiency syndrome, AIDS. And we can see that whatever we said with respect to malnutrition happens in HIV AIDS also. But what happens to the lymphoids? There will be lymphadenopathy. Whereas in malnutrition, it is a lymphoid atrophy. I'm only highlighting certain points due to interest of time. Next. And here we can see that like HIV AIDS, everything gets affected. Cell-mediated immunity is maximum affected. But look at the humoral immunity there. Immunoglobulin production is decreased. SIGA is decreased. Whereas in HIV AIDS, we usually have a hypergamma globulinemia. So the lymph node atrophy and the hypogamma globulinemia, especially the secretory IgA low, that is the clinching point. So the first line defenses are affected, the second line defenses are affected, the third line defenses are affected. Next slide. So the umbrella, the skin, the umbrella is lost for the baby. The baby is now right in the stome and brain. Next slide. And this is a bridge, that is the immune system bridge. See how it is strengthened. That is, it is heredity, nutrition, immunization, sex. Of course, female sex has a better immunological profile, we can say. Then adaptation and exercise. And here I want to tell you that there is a term called immunosenescence. That is, as age advances, our immunity will come down. And the only way we can manipulate is by continuing to do the exercise. If you continue to do the exercise, your immune system will keep on become active. And who is this? Postgraduates will know. This is Dr. Gopale. And the adaptation and disadaptation theory we have learned. And now we know more about the reductive adaptation. That is, reductive adaptation is the physiological response to the body during undernutrition. Next slide. And what happens? There is reduced physical activity and growth. This baby cuts down the activity, goes to a stage of hibernation, and reduces the basal metabolism and reduces functional reserve of the organs. And there is slowing of the sodium-potassium pumps and reducing the inflammatory and immune responses. The liver is at fault, the kidneys are at fault, the heart is at fault, the gut is at fault, sodium is leaking and potassium is leaking, iron is liberated, which is causing more of, may cause a lot of oxidative damage, muscle mass is reduced, immune system does not give the normal response. Look at the plight of the child. And the systems go to a shutdown. And so we have to, the baby has to be gradually brought back. Baby has to learn to function again. Functioning stopped. And who is this one? Is this person? This is Dr. Michael Golden. I met him at Jaipur conference. And he is the person who was behind this. Previously, when we see a SAM case or malnutrition case, we jump in with 200 kilocalories and 3 to 4 gram of protein on day one and give a blood transfusion also. So this person only said that we have to treat the baby like an inborn error of metabolism. No enzymes are working. So you have to be very careful. Start with 0.75 to 1 gram per kg per day of protein and little, and then so adapt the baby back. Next slide. So this reductive adaptation has to be thought of when we plan the management. Dr. Praveen Kumar is going to come with the 10 steps. So presume and treat infection. Why? We have already said. Then iron, be very careful with iron. Iron can cause oxidative damage. Free iron can promote bacterial growth. And when you give little iron, it has to be stored up. For conversion to ferritin, the baby will have to spend amino acids and energy. And provide potassium and restrict sodium. We have already seen that the pump is failing. Next. So only severe anemia we will treat then and there. Otherwise, we wait for 1 week for the baby to be stabilized and then give iron. So the do's and don'ts. Do not give diuretics to treat edema. Do not give iron during the initial phase. Do not give high protein formula. Do not give IV fluids. Next. What really happens in malnutrition is that this reductive adaptation, everything is centered around insulin. And insulin is a very powerful hormone than what we thought. And see here, insulin is low in kwashiorkor as well as in marasmus. But what happens? During refeeding, increase in insulin happens in marasmus. That is the success point of marasmus. Refeeding doesn't increase the response of in kwashiorkor. See, cortisol is increased. Next slide. They are catabolic. Growth hormone is high, again catabolic, and little bit of anabolic function may be there. And the next very important hormone is somatomedins or IGF-1 and 2, that is very low in kwashiorkor, low in marasmus, and there is glucagon is slightly high. Next slide. So we find that insulin is the key, which says that we should have glucose in our pool and it has to be utilized. Catabolism should be prevented. We can see that all other hormones may be counter-regulatory. That is the word we use, no? Next slide. So, based on this pathophysiology, we have now the 10 steps coming up. And I hope this will be very clear after the next presentation. Next.
Thank you, Dr.
For the time being.
Thank you, Elizabeth. A lovely presentation. Now, Dr. Shija, please inform our viewers, panelists, what the investigations were done for this child.
So as we have already seen, a very sick child with so much of nutritional dermatosis, naturally getting a blood sample is very difficult. So only the basic investigations are done and usually need to be done. And the investigations are showing an anemia with a hemoglobin of 6 gram per deciliter with a normal counts, 9,500 with polypredominance. There is thrombocytopenia, it's only 54,000. Sodium is 128 and a potassium of 4.5. There is mild derangement of OTPT, 70 and 40. There is severe hypoalbuminemia with albumin of 1.8. Urea is slightly raised at 32 with creatinine of 0.3. Routine urine as well as the chest X-ray was NAD. Nothing abnormal was detected.
Thank you, Dr. Shija. We now introduce another to a learned audience and stalwart in pediatric nutrition. When he's going to talk about how to confirm diagnosis, and that's identification of SAM. This is Dr. Praveen Kumar, is the director and professor of pediatrics, Lady Harding Medical College, and associated with the Kalavati Saran Children's Hospital, secretary and pediatric of Pediatric and Adults in Nutrition Society of IAP Nutrition Subspecialty Chapter. Special interest in pediatric gastroenterology, hepatology, and nutrition, infectious disease, and pediatric HIV. His contribution is the National Child Health Program, and like developing training packages for, on facility basis for management of children with severe acute malnutrition, and the FIMNCI. He's a resource person in many programs in nationally and internationally, and he's got 74 publications to his credit. Over to you, Dr. Praveen, for your presentation on the diagnosis of SAM.
So, thank you very much, sir, for a kind introduction, and I'm so happy to present this in front of IAP, Cochin, and people from Kerala. I have been to Potpourri, few NRCs you have there for the training. So coming to identification of severe acute malnutrition, for identification we need to take weight of the child, and this should be ideally on digital weighing scale with minimal flows as per climate and other. We have to take care regarding the hypothermia, so that is a precaution we have to take. Next slide, please. For children less than 2 years, we take length, and you need 2 people, and then you have to go to the next slide. For after taking length or height based on age, then we can use growth chart and determine the STS score of that child. And if the STS score is less than -3 standard deviation, this is one of the indicators for severe acute malnutrition which we have. You can also use WHO Anthrop. You have different software to use this. You can use IAP charts and calculators which we have. Next. The other measurement which helps us is mid upper arm circumference for children between 6 to 59 months. Also upcoming is less than 6 months, but is at this point of time that is in research mode. For 6 to 59 months, if it is less than 11.5, then this indicates severe acute malnutrition. Next slide. In addition to this, and particularly we are dealing here with a child with edema, and we have dermatosis, particularly these children. One of the additional assessment which helps us is looking for bilateral pitting edema, and this should be bilateral and pitting type as shown in this. And then we grade it according to severity. Already this child had ascites, which indicates there is generalized edema in this child. Next slide. So when we use less than 6 months, if the weight for length is less than -3 standard deviation, for infants more than 45 centimeter, or visible severe wasting for infants less than 45 centimeter, because we do not have STS score in this for this length, and or bilateral pitting edema of both feet without a known cause. If we have a known cause, then we are not using. When we do not have a known cause, then this is one of the independent criteria. While severe acute malnutrition in 6 to 59 months, you also have added criteria of MOAC less than 11.5 centimeter. And if it is weight for height between -2 ST to -3 ST, then we say this is moderate acute malnutrition, and MOAC 11.5 to 12.4. Most of time, although previously we were using this marasmus and Kwasarkar, Nowadays, the WHO, most of the places, they use this edematous and non-edematous malnutrition in place of marasmus. So I think these are already covered by Dr. Elizabeth ma'am, the physiology regarding the changes, these liver changes. Then they do have changes in gut, which has management implication. So coming to how do we decide, you must be aware there are 2 levels of care. And these children with severe acute malnutrition, once we identify, then we have 2 criteria. We are looking for medical complication. We examine for medical complication. And then we look for appetite. If the child has any medical complication or the child has poor appetite, then that child will require primarily care in facility or a hospital where SAM management facility is available. While children with SAM without any medical complication, and if they have good appetite, they may be managed in community-based program. So coming to history and examination, already we have gone through the history and examination, but certain important points. We have to look for any emergency sign. We have to take anthropometric parameters, some vitals, and then we, especially we need to look for eye signs of vitamin E deficiency, which are already have been highlighted. Skin changes, as you can see here, this child presented with dermatosis. And then we have to look for systemic examination, because many a times you may have secondary cases, secondary cause presenting as severe acute malnutrition. So we need to rule out secondary causes also in these cases. Next. So also loss of appetite, we have to see, we are particularly in these children, you have to rule out possibility of tuberculosis, you have to look for possibility of HIV. Particularly if there is a history of measles, then this has bearing in immunization and health of the parents, particularly again for ruling out HIV. So these are the important history and which usually helps you in deciding. Thank you, sir.
Thank you, Dr. Praveen. Now we'll have Dr. Sridhar discuss management of SAM and the recommendations that are available now for the management.
In fact, what we did for this child, that's what I would be discussing. So the child at admission, the child had hypoglycemia. GRBS was only 32. But with the amount of edema and the dermatosis, getting an IV line or attempting an IV line at that time was not found to be, was not thought right. And so immediately an NG tube was put and D10 was given through the NG tube. The plan was to start refeeding with F75 half-hourly for the first 2 hours to prevent hypoglycemia. And meanwhile, the baby was covered with warm clothes, including cap and socks, if you remember that the child also had hypothermia. And the child had come to you with a complaint of diarrhea. Now we want to know whether the child is dehydrated or not, to decide whether you want to give rehydration or not. So eyes and oral mucosa were dry. But then we all know that in case of when you have malnutrition, you can have atrophy of the lacrimal glands as well as the salivary glands, which may contribute to dryness. With that much of edema and that bad a skin turgor elicitation was not possible. There was no obvious tachycardia. The heart rate was around 128. Of course, the CFT was prolonged at 3 seconds. One sign which was indicating towards a dehydration was an AF which was depressed. And of course, there was a history of recent change in appearance of eye. The mother feels that the eye was looking a little sunken. There was history of passing large amount of watery stools. Sensorium was poor. The child was not taking orally. So rather than having thirst, in fact, it was the other way around. And of course, there was a history of a decreased urine output. So with these, we concluded that the child definitely has dehydration and the child requires rehydration. So before starting rehydration, the first most important thing is to check the weight of the child and also ensure that an accurate weighing scale is by the side of the patient to be so that you can recheck your weight or monitor the weight gain at intervals. So that was also ensured. The liver edge was marked to see that you are not going in overhydrating the child. The heart sounds were again auscultated to see that you're not dealing with a child who's already looking pale. The child is not in failure and you may be worsening the condition by giving fluids. And a monitoring chart was put where along with the vitals, the weight was also plotted to see that the weight gain and weight loss to be documented. Because when you have a child with severe acute malnutrition with edema, the most important finding that tells you about the hydration status is definitely the weight. So if you had a pre-diarrheal weight, our aim would be to achieve that weight. If you don't have a pre-diarrheal weight, we assume that depending on the severity of dehydration, you would have assumed whether you want an 8% increase or a 10% increase, depending on what your assessment is, and repeated reassessment of the child will decide that. So with that, Rosomal was used for rehydration. Rosomal was prepared by diluting 1 sachet of ORS in double the amount of water and adding extra potassium as well as sucrose. So that was part of the rehydration that was planned. Meanwhile, we already said that the child had come with hypoglycemia, and so you were planning to give F75. F75, we already know that it contains 75 calories and around 1 to 1.5 gram protein. When you have a child with kwashiorkor, the most important thing is you want to limit the fluid intake to 100 ml per kg. If it was marasmus, we would have aimed at 130 ml per kg. But we should understand that when you're giving an F75, you're only giving 75 calories per 100 ml. That means in a day, you're going to give only 75 calories per kg per day with a protein of just 1 to 1.5 gram. So the question is, when a child is coming to you malnutrition with hypoalbuminemia, with in a very malnourished state, why is it that you are going for a low calorie, low protein diet? You need to remember, especially in kwashiorkor, the 50%, next slide, 50% of the liver is replaced by fat. So it's a fatty liver, which is leading on to, you are finding a hepatomegaly there. So the function of the liver is grossly compromised. Similarly, if you see the intestines have all atrophied. So the absorptive capacity is less. So if in this condition, if you're going to give more feed, you will end up having a diarrhea. On the other side, if you're giving a more protein-rich fluid, as madam has already said, that it is like a protein, it is like an inborn error of metabolism, a protein metabolism error, and you stand up giving a high protein diet, you may have hyperammonemia with its consequences. So always remember, when you're starting F75, your aim is not weight gain. You are just trying to recover the normal metabolic function. That is, there is a metabolic malnutrition. You just want the metabolic malnutrition to be corrected. You just want the enzymes to be synthesized, so that once the enzymes are synthesized and they are working, then when you give your food or increase the calorie and protein, the body will be able to manage this better. Next slide. And most important thing that we have to understand is that when you are giving a large amount, what normally happens, madam has already beautifully explained that what happens in a starvation or malnutrition. In a starvation or malnutrition, you have a reductive adaptation. So what does your body do? Next. So what does your body do is you have glycogenolysis as well as gluconeogenesis. So protein and fat, amino acids, and this thing are being used for synthesis of glucose. So when you are refeeding and you're giving a carbohydrate-rich food, so body switches on to anabolism. Anabolism means there is an increased secretion of insulin from the pancreas in response to the carbohydrate load that you are giving. And when you are giving this, when the insulin is increasing, the insulin will drive the glucose inside the cell. And inside the cell, it leads on to increased protein as well as glycogen synthesis and fat synthesis, which leads on to increased utilization of potassium, magnesium, phosphorus, as well as thiamine. All these things enter inside the cell. So once your electrolytes are going inside the cell to take part in the metabolism that is being that has started inside the cell, it leads on to hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, and salt and water retention. Of all these electrolyte imbalances that happen in a refeeding syndrome where you have rapidly advanced your feeding, the most important is the hypophosphatemia. The hypophosphatemia, once the phosphorus level comes down, remember phosphorus is is part of many of your things. ATP contains phosphorus, ADP contains phosphorus, your protein contains phosphorus. Phosphorus is needed for your signal transmission. So this is going to cause, so hypophosphatemia will lead on to worsening neurological status. You can have rhabdomyolysis, you can coma, seizures, you can have hemolysis, the leukocyte function comes down. In fact, the thrombocytopenia happens, the platelet count comes down, the platelet function gets affected. So there are multiple abnormalities that happen due to hypophosphatemia, secondary to refeeding syndrome, and all these can lead on to death. So that is the reason why you always try to do a slow refeeding. So that is very important. And in infants less than 6 months, You should remember that you can use F75. That is not mandatory for this child. We had given infant formula because WHO now recommends that for less than 6 months, you can either give an infant formula or F75 as the starting feed, because an infant formula also contains less of protein and less of calories. And once they go to the next stage, when you want to use F100, it is always F100 diluted that you use, because the small baby will not tolerate such a large solute load. Next slide. So the plan was in phase 1 to give F75 or normal formula, and once the appetite improves and the edema decrease, transition to F100 diluted. And once the edema subsides and a good appetite, then go on to phase 2 or the catch-up phase. So it is in the transition phase also, the most important is you limit to 100 ml per kg per day. You don't increase the volume. And F100, we know it provides you with 100 calories as well as 3 grams of protein every 100 ml. And here you're going to use diluted F100. So once the edema subsides, the transition phase is over and the child goes on to phase 2. Then our aim is to progressively increase the calorie as well as the protein intake. That is after the edema has subsided. Till the edema is there, you are not going to increase neither the calorie intake nor the volume, fluid intake. That is most important. So after the transition phase, you're aiming at 150 to 220 kilocalorie per kg per day and 4 to 6 gram protein per kg per day. Meanwhile, during the course of treatment, always try to re-establish the lactation and encourage to continue the breastfeed. Now coming to the electrolytes, Madam has said that in SAM, you have a sodium excess because your sodium potassium ATPase is not working well. So the sodium, rather than remaining extracellularly, goes intracellularly. So serum sodium may be low, but your total body sodium is high. On the other side, potassium remains outside the cell and gets excreted in the urine. So total body potassium is low. And magnesium deficit is there. It contributes to the edema as well as to the leakiness. So next slide. So it is important that we should not be adding salt to the diet. And in case an IV fluid, as far as possible, avoid using parenteral fluids. Always try to use your enteral, whether for rehydration or for feeding. How the child survives, or if the child survives, and that depends upon majorly what you have used, whether you have opted for a parenteral or the enteral route. Enteral route is the one that saves the life. So sodium should be low. And potassium, next slide, potassium supplementation should be provided, usually 3 to 4 milliequivalents per kg per day. And these electrolyte supplements are continued for the first 2 weeks. And please remember, when you see a grossly edematous child, never have the tendency to give a diuretic to see those dramatic responses, because diuretic is going to increase the loss of potassium and make the electrolyte imbalance worse. So it is very important that when we are managing a child with malnutrition, we should have all the patients needed. You are not going to see miracles happening in 1 or 2 days. You will see a miracle happening in a week or a month. And magnesium, first day you give a higher dose, 0.3 ml per kg, can be given IM, and subsequently the same injection magnesium is given orally at 0.4 to 0.6 millimoles per kg per day. Regarding the vitamin supplementation, usually you will give double the recommended allowance. Vitamin A, I want to add something. Usually vitamin A mega dose is not recommended in children with kwashiorkor. So usually you're giving a mega dose on day 1 in marasmus when they are admitted. So we used to recommend vitamin A only during the third phase or the phase 2. But now the WHO says that not giving vitamin A to a child with SAM with edema leads on to increased mortality, increased severity of diarrhea, as well as increased incidence and duration of respiratory infection. So now, even for children with kwashiorkor with edema, vitamin A is recommended, but not as mega dose, but as 5,000 units daily. And of course, zinc, copper, and other multivitamin has to be supplemented. Folic acid, a higher dose on the first day and subsequently a lower dose. Usually for children with less than 6 months, you just give a unique dose of folic acid. Then, of course, Madam has already said that we are not going to give iron because iron will cause free radical injury. Iron will increase the chance of bacterial infection, as well as this iron needs to be converted to ferritin, because that is what a baby in marasmus or kwashiorkor is going to do, and that is going to require more energy expenditure. So you are putting a child under stress by giving an iron. So iron will also be started only in the rehabilitative phase and not initially. Every child with SAM admitted, you have to presume that the baby has infection, whether the baby shows you overt signs of infection or not. For the relatively stable ones, definitely you will go for an oral antibiotic, and the sicker ones you may prefer to go for for a parenteral antibiotic. So what were the issues that was faced? The issues faced for this child at admission was there was hypoglycemia, poor activity, anemia, and thrombocytopenia. The child had loose stools with evidence of dehydration. But unfortunately, day 2, in spite of all this monitoring, you realize that the weight, instead of weight loss, you are finding a weight gain of 200 grams. The dermatosis seems to be worsening and the edema seems to be increasing. Unfortunately, the loose stools were persisting and worsened by day 3. The child also had vomiting, and child went in for a hypotensive shock that necessitated an IV resuscitation. Initial fluid bolus was given through ringer lactate, and subsequently the serum sodium had jumped up to 170 milliequivalents per liter, with potassium falling to 3. And meanwhile, the child also had a new onset respiratory distress, and chest X-ray was showing pneumonia on the right side, probably due to aspiration. So having said that, we pass it on to Dr. Praveen Kumar to discuss the complications and treatment.
Yes, Dr. Praveen Kumar will now enumerate the complications that are encountered and their management.
Okay, so thank you. And regarding the development of case, what are the common complications which we should look for? We should look for anemia in all cases, because you have deficiencies, and micronutrient deficiency is one of them. So please look for anemia. Ma'am has already highlighted the indications for blood transfusion. Next. And then we have to look for eye complication, and particularly if we have a child who is not able to see in bright light, and then you should suspect underlying vitamin A deficiency. And also one should look for the clinical signs of vitamin A deficiency, because I could see a few questions coming in chat box regarding the dose, whether we should give mega dose or not. So it's very important to look for eye complications, particularly vitamin A deficiency. Next slide. So these are the changes, and I think because of the lack of time, I will skip this. We already have highlighted this child presented with dermatosis, and dermatosis, children presenting with dermatosis, it's a real challenge in managing these cases, particularly dermatosis, because you have entry of bacterial pathogen, the risk of infection is high, and most of time it's difficult to manage them. Next. So just to highlight what are the medical complications, presence of any emergency sign, you will have to admit them in the health facility. Next. If the child has diarrhea with dehydration, again, they should be admitted. And also, next. If the child has bilateral pitting edema, you may see this is not indication, but same time in India, we do not see this edematous malnutrition commonly. And most of time you may have secondary causes. So we prefer, and as per our national guideline, if the children with bilateral pitting edema or edematous malnutrition ideally should be managed in health facility. The same time, high-grade fever, fast breathing, and persistent vomiting, hypothermia, these are the additional indication. Or if you have some clue for no secondary causes. Next. Also, when we do not have this moderate to severe medical complication indicating hospitalization, then we do this appetite test in nutritional rehabilitation center to decide whether the child will need, because if the child has poor appetite, this also indicates underlying medical complication. And most of time the appetite test is recommended is with RUTF, which is not available in this country. So most of the places we use this F100 diet, or there is a feed called a special feed, which we prepare in NRC. And this is the amount suggested. And if the child is finishing that much amount of a special feed, then we say the child has passed appetite test. And as I mentioned initially, if the child has passed appetite test and he is not having medical complication, then this child will be managed in community-based programs. or if the child has poor appetite or medical complication, then that child will be admitted in health facility. Next. So already ma'am has highlighted these 10 steps. These 10 steps are nothing but to tackle the common complication. And most of the even district hospitals, if we follow these 10 steps, 80 to 85% of the cases we will be able to successfully manage. You may have 10 to 15% where you will need additional investigation. Next. So the first step is treating and preventing hypoglycemia. Hypoglycemia, we say when this blood glucose is less than 54, and all SAM children admitted in health facility, we should have this soon after admission. And if the child is asymptomatic, we give them 50 ml of 10% dextrose or sucrose orally. And if the child is symptomatic in form of lethargy, unconsciousness, then you will have to give them IV dextrose 5 ml per kg, followed by 50 ml of 10% dextrose. Next. Then I think there was again comment. Next slide, sir. The second common complication is hypothermia, and one should look for hypothermia, although it's mentioned core temperature, but routinely we usually monitor auxiliary temperature. Auxiliary temperature less than 35 indicates hypothermia. And when there is hypothermia, you can use kangaroo mother care, skin to skin contact, or if there is this facility is there, radiant warmer to use, maintain temperature. Also, it's important to prevent by maintaining the room temperature, which should be ideally kept like any new nursery, and the recommended temperature is 25 to 30 degrees. Prevention is by frequent feeding, which we give initially 2 hourly. Particularly, you should take care that the child is covered, particularly in the night. You promptly change wet clothes, and also you take care and when you are taking weight or you are sponging the child. Next. The management of dehydration, as already highlighted, is difficult, and particularly why? Because the usual signs of dehydration, which we usually use for normal children, they are usually not reliable. And even senior experienced pediatrician, they usually have difficulty in deciding the level of dehydration. Next slide. So how do we treat this dehydration? Already highlighted by Dr. Sija. We have to take this, and Resomal is not available in our country again. So what we use routinely is called modified ORS, which you prepare with low osmolality ORS. You dilute this up to 2 liters and also add pot chlor and glucose. Next. So we monitor for signs of any overhydration. And how do you do this? You monitor the respiratory rate and pulse rate. If there is increase in respiratory rate by more than 5 and pulse rate more than 15, this indicates there is overhydration. And if you are not able to pick up, then the other parameters are increasing size of liver, rapid weight gain, and other parameters. So that's how you have to do. Only 2 exceptions for modified ORS are if the child has profuse diarrhea, that we say if there is more than 10 watery diarrhea, or if the child is suspected cholera, then you use a standard ORS without any modification. Then in those cases, you don't use modified ORS. Next slide. So I think already the only indication for IV fluid in SAM child is when the child is in shock, and we have to follow these management. We have to give them IV fluid. We have to give different fluids, that is 15 ml per kg of either half normal saline with 5% dextrose, or linger lactate in 5% glucose. So that is what we use for resuscitation of these children. Next, and once the child is slightly better, you shift to oral as we have described. And the overall correction is over 10 to 12 hours. And most of the time, once you start orally, the child is able to take, then you give it alternating with starter diet or F70 diet. It's also important because septic shock is also a strong possibility. If there is the child general condition deteriorate any time, then you have to keep a possibility of septic shock. In that case, you have to switch over to maintenance IV fluid, and you have to start no vasopressor and consider ensure the first dose of antibiotic. Next, I think next already electrolyte imbalance and micronutrient supplementation already has been covered. The only point which I just wanted to highlight that you have at this point of time, you have both commercial preparation being used in few states like Maharashtra and Gujarat. All these commercial preparation, which is known as F75 and F100, this already, they have potassium, magnesium and all these. So you don't need to supplement when you are using these commercial preparation of F75, F100. But when you are using locally prepared, this is starter diet and catch-up diet, then you will have to supplement this potassium, magnesium from outside. And similarly, you will have to add zinc and other components. Next. This treating infection is already covered. So we have already, this is the national guideline which is shown in this slide. All children, they receive antibiotic. Next. So you have for different condition, and this should be given for most of the cases will need 10 to 14 days unless the child has meningitis. Next. I think it's already highlighted, covered by Dr. Caesar, so I'm not spending time here. Only vitamin E already has highlighted, but there was question if the child has vitamin E deficiency, whether it is edematous or non-edematous malnutrition, you will be giving them 3 doses of mega dose antibiotic. When they are not having eye signs of vitamin E deficiency, in that case, you will wait till edema subsides and then only you will give. It's true that the WHO now recommends 5,000 daily dose, but it's difficult to administer. Particularly, this is possible when we are using commercial preparation. So meeting those requirements will be difficult. So these still we are using as per national guideline. 1 mega dose is recommended in edematous malnutrition also once edema subsides. But it's true, you should not use initially. Regarding micronutrient, other deficiency already covered by Dr. Caesar, so I'm not spending. I am just time here. There was some question regarding copper. The only problem is we do not have any commercial preparation which will meet this copper requirement of child. Otherwise, you can supplement other from outside, if particularly you are using locally prepared therapy. So I think that was all which I was.
Thank you, Dr. Praveen, for that excellent presentation. So despite this proper management, the child is not, if the child is not improving, what are the alarm bells? What are the danger signs, and what would you do, Dr. Shikha? No, unmute, please. Unmute.
So when do you say that the child that you have failed in your treatment? Next slide. So usually if there is a failure to regain appetite by day 4, failure to start losing edema by day 4, or presence of edema on day 10, or failure to gain weight at least 5 grams per kg per day by day 10. So these are taken as primary failure of treatment. So let us see what happened to our child. The child which had come with a weight of 6 had increased to 6.2 the next day, and the day after that, it had again gone up to 6.4. And by 4th day, it was still sitting at 6.2. That means, in spite of your meticulous monitoring and management, the weight was not even the admission weight. The weight had in fact increased. The edema was worsening. And what happened to the baby? Next slide. Since we said that, so once the child went in for a hypotensive shock, and after the initial bolus from the ward, the child was shifted to ICU, where IV rehydration was continued with half RL, with hourly weight monitoring to decide what is the amount of fluid that you want to give the next hour. And NIV support was done for the respiratory support, for the respiratory distress. Antibiotics were upgraded, and all fluids being given was documented. So that is very important. So why did the first day, in spite of your management, why did the weight go up? So there, the importance is that after every feed, because the feed was given through the NG, the mother was giving 10 ml of clear water. So 10 ml clear water 2 hourly adds on to 100 ml, and that's a significant amount in a child, in a small infant, 6 kg. So that is one of the reasons why you are having some hidden fluid going in, which is responsible for the edema worsening. So fluids being administered in any form, whether it is rehydration, whether it is the feed, whether it is the drugs, has to be accounted for, especially when you're managing a case with a kwashiorkor. And NG feeds were naturally continued once the GI was under control and relactation was established using the supplementary suckling technique. Secondary failure, once the edema has subsided, and for this child, it took quite a long time. It did not subside in 5 days or 10 days. It took close to 15 to 16 days for the edema to start decreasing. And once the edema has subsided, you have to see what is the weight gain. If you are having a weight gain of more than 10 gram per kg per day, you should pat yourself, you should be happy. But if it is less than 5 gram per kg per day, you need a complete reevaluation. There has to be something grossly wrong, why the weight gain is not happening in spite of you giving the required calories and protein that is recommended. So next slide. So what are the things that should cross your mind? Is there an inadequate feeding, especially if the mother is skipping the night feeds? That could be a reason. There may be an extra loss in the form of vomiting and diarrhea. There may be specific nutrient deficiencies. If you don't correct all the nutrient deficiencies, again, your enzymes are not going to act and your recovery is going to take time. And most importantly, think about untreated infections. We all know, excuse me, we all know that in children with SAM, the signs and symptoms of infection are not overt. A child with pneumonia may not have tachypnea. A child with sepsis may not have fever. So it is very important to look for infection, urinary tract infections, respiratory infections, screen for them whenever you find that the child is not doing well. And also psychological problems and immunodeficiency should also be thought of. So what happened to our baby? After a prolonged hospital stay of 1 month, finally the baby went back home with a lesser weight, a happier baby, and a cuter baby. Thank you.
Thank you, Dr. Shija. Lovely. Dr. Praveen, so what would be factored in following up these children who have been rehabilitated in your hospital?
Yeah, so as per this, most of time the children rehabilitation and meeting the discharge criteria usually takes 7 to 14 days. In our NRC, the mean duration of a stay is approximately 10.6 days. That is the average which we last analyzed. And more before discharge, we have to make sure that the child is on mixed diet, and which mothers can give at home. And we have to organize, and particularly we have to teach mother and involve them in the preparing food, feeding the children, bathing and changing clothes, and sensory stimulation and play therapy, which is important. And also we have to take care of maternal nutritional status and counsel her regarding the family planning and other supplementation. So this is few of the picture from our NRC, which routinely we organize them these counseling session. The mothers are involved in feeding. The food demonstration is there. Next slide. So when do we discharge? Before discharge, whenever we plan, then we give a dose of anti-helminthic, which is usually given 12 to 23 months children 200 milligram albendazole, and more than 24 months 400 milligram albendazole. Before also discharge, we try to link them with the nearest Anganwadi center where they can get follow-up after discharge. And then all children are kept under follow-up for 3 to 4 months. Usually this is variable in different states because we have to ensure the food recovery. Next slide. So this is the discharge criteria shown for postgraduates. There are additional criteria which you see here for the child. He was 15% weight gain, which WHO 2013 update they have removed it, and because most of time it's not practical to keep them for 15% weight gain, but this is what we want to achieve. The same time, the mother also should be able to these and should perform these, identify dangers, signs, preparing nutritious food, because the child will be going in same environment. So we have to take care of this. Next slide, sir. And so we have now separate criteria for discharging from a nursery or hospital and then discharging from program. For program, we use weight for height equal to or more than -2 st. This is what we want to achieve. And the child is eating adequate amount of food and the child is clinically well and alert. That is what we want to achieve. Next slide. This is the most of time the follow-up plan. First is at NRC 15 days after discharge or 7 to 15 days. Then second one is by ASA by their home visit. Third also home visit by ASA. And last one they are coming to NRC for final follow-up. So I think this is what we follow, and each follow-up, what all we should try to look is we will have to examine for medical complication. We need to see whether the child is gaining weight or not. We look for any edema, and then also we inquire about the feeding practices and play activities, whether mother is able to perform that or not. And wherever there is a need, we try to reinforce this. Next.
Thank you.
Thank you.
4 months of follow-up. Dr. Elizabeth, now Sam we encountered today is not the same sort of cautious we used to see it in yesteryears. What is the hallmark of the changing profile of Sam?
Yes, there is a changing profile of malnutrition. We see that we have stunted children, wasted children, overweight children, and obese children. And look at this global hunger index. Where does India stand? It is in the dark yellow. That means it is severe. And global hidden hunger index, that is cumulative index of iron, vitamin A, and zinc. That is also, we are in the severe, that is the brick color. So we are having a lot of malnutrition. And if you look at the deaths, IUGR, stunting, wasting, zinc deficiency, vitamin A deficiency, suboptimum breastfeeding, these are the highlights of cause of mortality. Next slide. And look here, 36% are underweight, and out of that, 21% are wasted, and severely wasted is 7.5. So, moderate acute malnutrition is there, and lot of them are moderate acute malnutrition. But if they develop some sepsis, skin changes like that, they will immediately break down and become kwashiorkor or edematous Sam. So this State of the World's Children 2019 is highlighting the changing face of malnutrition, and 1 in 3 children is not growing. That is the UNICEF saying. Undernutrition, hidden hunger, overweight, obesity, stunting, wasting. And there is a change in our food system, food environment, food desert, and food swamp. These are new terms which are coming up. Next slide. So nutrition transition is there, and food desert is that no healthy food is available. And look there, what is food swamp? Or more unhealthy food is available than healthy food. That is what we see in our part of the country also. Next slide. And the cost of malnutrition is going very high. Next. Recently, I was asked to write in the encyclopedia, and I was writing the transition from the marasmic to the obese, and from the kwashiorkor changing from a toddler to a young infant. Next slide. So we have the SAM and the edematous SAM. Marasmus was known even during the era of Hippocrates, whereas kwashiorkor came in 1950s when Dr. Cicely Williams described. And she said it is the disease of the deposed child. It occurs 3 months to 3 years. But we are presenting so many cases of young infant with edematous SAM. Next slide. Next slide. So this is Cicely Williams, and Dr. Cicely Williams said we will have to accept the term of kwashiorkor till the pathologists and chemists can give us more insight into it. And she said it is kwashiorkor, that is koni oshi korkor. That means pretend not to mind the korkor means the second child. And in 2013-12 itself, in SAT hospital, we were seeing this changing profile. Edematous SAM with because of early lactation failure. This is from my 5th edition book 2015. Early lactation failure, as Dr. Shija was telling, that is a cause for the infant kwashiorkor, like edematous SAM. Next, marasmus is easy to treat. Most of the time they do not have medical complications and they do well. And here I must say that if I ask many of my colleagues or friends, are you seeing SAM cases? They say no, but we have to look for the high risk cases. That is too weak or feeble to suckle effectively. We see many of the NICU, NICU graduates coming like this, too weak or feeble to suck, feeding problem, independent of the weight for length. So if you are looking for this, we can pick up early cases and start intervening, and then this changing phase can be brought back. And we started seeing it in SAT. Then we heard that Trishur is seeing, Kozhikode is seeing, now Ernakulam is seeing. So wherever we go, we are seeing small babies, infants with kwashiorkor, absolutely not because of lack of food, but because of lack of nutrition counseling and the wrong social impact. That is all the media telling them. Recently, one major women's magazine gave one full page telling that start complementary feed at 3 months. Your baby will sleep so well and you will be so, the baby will be so good. So we have to counteract that. And they have written below that, even though the World Health Organization says that complementary feeding should be started only at 6 months, we can start. See this baby, what happened. I think this is my last slide. So if we anticipate, you will be seeing. And these NICU graduates who are too weak to suckle or having feeding problem may not come back to you. They may die in a local hospital or they may die at home. So we have to look out for that. Thank you very much.
Thank you so much, everybody. It was an excellent presentation. I will we'll go on to yeah.
Yes.
Elizabeth, Dr. Sulega.
Yes.
Do you see acrodermatitis less than 6 months baby who are exclusively breastfed? Have you seen?
Acrodermatitis per se, I have not seen many cases, madam. This sort of nutritional dermatosis mistaken as acrodermatitis, we are seeing.
Okay.
Acrodermatitis, that genetic condition, we have not proved many cases, but some of them may be having because zinc is given by the local practitioner or dermatologist already, and the mother will be continuing that.
Okay, thank you.
Now, I think we'll take a few questions if there's time. One is from, I think she just answered it.
Most of the things we have answered, sir.
See, I think we should, because all the other participants would like to hear the answers. So one was on potassium. What was that question? Shija, you had answered that question. What ideal fluid choice? Ideal fluid choice in a child with chalk. And kwashiorkor and chalk.
Okay. There were two questions. That is, one is why was the potassium low in the child with
Dr. Shanmuga asked that, yeah.
Yeah. Why was the potassium low even though the child was getting rehydrated with ringer lactate, which contains potassium? Here, the potassium is low because the child is, when that potassium level is being sent, the child is still in dehydration. So the rehydration is continuing and there's considerable loss of potassium in the stools. At the same time, the total body potassium, as we all know, in a SAM child is low. So everything contributing to the low potassium in the child. The next was, which fluid do you use for rehydration? We already said that whenever you have a SAM child, or if you land up giving an IV fluid, you have to always take care of the sodium levels. Even a single or two boluses of a high sodium fluid like an NS may just shoot up the sodium levels. So if the patient is in shock, the preferred fluid is half NS. And SAM is the only condition where you're using half GNS. That means you're using a dextrose containing half NS, or you can use half RL with 5% dextrose. That is, you use equal amount of D10 and RL. That will give you D5 half RL, so that the sodium doesn't go up.
Okay, Dr. Nisha was the one who asked whether, if the IChin is already, can you use mecha dose? And I think Dr. Praveen has answered that. What does Shija, what do you What did you say to that? Dr. Praveen, you said that if there are eye changes of vitamin A deficiency, you would give a mega dose.
Yeah. So whether it is edematous or non-edematous malnutrition, if they have eye changes on admission, we have to give mega dose.
So how do you identify copper deficiency? And you said copper is not available. How do you identify copper?
I said usually the preparation will not be able to meet the requirement and supplementation which we have at this point of time. We do have certain preparation where we do have some copper, but most of time we are unable to meet the requirement. So that is the no problem with current management or whatever preparation we have. So that is the limitation of whatever.
That vitamin mineral mixture we are not having in India.
Yeah.
That is the issue.
Yeah. Dr. Neduncharyan has asked prevention of hypothermia. What do you do in the NRCs?
So NRC, as I mentioned, if it is mild hypothermia, we use prefer skin to skin contact. And if the child has no severe hypothermia, then we go for radiant farmer and all whatever the neonatal management is. Same principle we have.
Dr. Jayakumar has asked, address the root cause, breast abscess. Keep mother's finger into the mouth of the baby. Would when you remove the baby, I think his breast engorgement and prevention, is that what he's talking about? I think Dr. Elizabeth, can you answer that?
Yeah, that can be advised. Even forceful letdown also. Some mothers, they say at the start of the feeding, the baby chokes. And so we tell her to put the finger and relax the vacuum and then take it. So that can be practiced.
Dr. Thangavailu's asked, what about cow's milk protein intolerance and celiac disease? Can that be a differential for Kochi?
See, we are at here in the belt where celiac disease is so common. We don't see celiac disease cases at 5 months of age.
Yeah.
You need to exposure with gluten containing food item, and then you need some time when they will have intestinal changes. And so celiac disease cases don't present like this dermatosis which we have seen. So I don't see celiac disease coming as one of the differential diagnosis. Regarding cow milk protein intolerance, if you see initially you may have this, the CMPI, they can present with diarrhea, there is urticarial and rash is there. But again, we do not have the skin dermatosis which we have seen in this case. And most of time, we have usually blood mixed diarrhea in cases of CMPI. So that is what we have to see. And most of time, this child has improved on management and the ma'am has used infant formula. So it looks unlikely that no, because you have not eliminated this cow milk protein and the child was managed with this. So that possibility initially one can keep, but ultimately this is ruled out.
Okay, Dr. Elizabeth, why don't we see so much of marasmus here? Do we see marasmus in India?
Yes. That is more common, I think, except in Kerala.
Yeah. So let me say, tell you, sir, we have already publication and analysis of NRC cases. So most commonly, more than 95% you have marasmic, and less than 5% you have quasar.
I think in Kerala, we are seeing this early lactation failure cases. That is why we are seeing this sort of small edematous malnutrition. Otherwise, marasmus is the common one. Those who adapt, and go like that.
Okay, we'll go on to the quiz. I think Dr. Pramod, you want to say something about the quiz? Anyway, I think
it's already put on the chat box about how to answer the question.
Okay, so the first question is here. Regarding nutritional requirement during childhood, all the following are true except. You can start answering now. Oh, sorry. The first question, I think, so nutrition and growth during 3 to 6 years of life predict adult stature and some health outcomes. Major risk period for growth stunting is between 4 and 24 months. EAR is the average daily required nutrient intake level estimated to meet the requirements of 50% of the population. RDA is an estimate of the daily average nutrient intake to meet the nutritional needs for 97% of the individuals in a population. The three components of energy expenditure are BMR, thermal effect of food, and energy for physical activity. I think we've got your answers. Next question is adaptive adaptation is a process of evolution to a state of full malnutrition. All the following events will be ensued except liver makes glucose less readily, less heat production, gut produces less gastric acid and gut enzymes, there's evident response to infection, and reduced red cell mass. Emergency treatment in severe acute malnutrition include all except shock, hypoglycemia, dehydration, severe anemia, and micronutrient deficiency. The aim of rehabilitation phase in the treatment of malnutrition is to repair cellular function, correct fluid and electrolyte imbalance, restore homeostasis, catch up growth, and prevent death from infection. Hallmark of refeeding syndrome is the development of severe hypophosphatemia, hypokalemia, hypomagnesemia, hyponatremia, and hyperglycemia. Thrombocytopenia and refeeding syndrome is mainly a result of hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, or hyperglycemia. All are correct about vitamin A supplementation and SAM child except all SAM children with signs of vitamin deficiencies receive 3 doses of vitamin A on days 1, 2, and 15. Infants less than 6 months are given 50,000 international units. All SAM children should receive 1 dose of vitamin A unless they have received one during the last 1 month. Vitamin A dose should be delayed till edema subsides unless the child has signs of vitamin A deficiency. An 18-month-old SAM child with a weight of 6 kilos should receive 2 lakhs international units on admission. Species of kwashiorkor include all except diagnosis of dehydration is by history of watery stools and decreased urine output. Serum amylase, esterase, choline esterase, lipase, and alkaline phosphatase will be elevated. Pneumonia may be identified only by chest X-ray. Urine microscopy and culture are required to diagnose the commonly associated UTI. The ECG changes include flat P wave, increased corrected QT interval, flat to depressed T wave. Points to remember when initiating feeds for a child with SAM, all are true except only feed children with a SAM in appropriate feeding position and should be supervised. Caregiver should never eat his or her food in front of a SAM baby. For all babies, initiate feeds at 130 ml per kilogram per day. Breastfed children should always suckle before diet on demand. Sufficient intake is defined as more than 80% of prescribed diet. The last is, all of the following are correct about identification of children with severe acute malnutrition, except length should be measured if a child is less than 2 years old. 3-year-old unable to stand, 0.7 centimeters added to the measured length. You convert it to height to calculate the weight for height standard deviation score. For all infant with length of less than 45 centimeters visible, severe wasting is used to identify SAM in place of weight for length less than 3 standard deviations. Marital pitting edema without a known cause is an independent criteria to identify SAM in both less than 6 months and more than 6 months age group. And MUSC of less than 11.5 centimeters is an independent criterion for identification of SAM children aged 6 to 9 months. Okay, thank you. So that's the while Dr. Pramod is calculating the winners, I will go on to the next slide, where our faculty will be explaining what are the right answers. And we'll start with Dr. Elizabeth for the questions for to 4. Dr. Elizabeth.
Yes. So the first question, obviously, I think this was a very simple question. A is the correct one. We know that nutrition and growth and the adult stature is more dependent on the first 1,000 days. We can extend it to 3 years. Major risk period for growth stunting is between, that is correct. Then EAR is for that is the estimated average requirement covers 50% of the population, and the recommended dietary allowance 97%. And the major 3 components of energy expenditure is BMR, thermic effect of food, and energy for physical activity. The rest are, the next will be growth and fecal loss. Next. So A is the answer. And in reductive adaptation, liver makes glucose less readily. We know that is correct. So we have to pick up the wrong one. Less heat production, that is correct. Then gut produces less gastric acid, that is true. And evident responses to infection, that does not happen. And reduced cell mass is there. So the answer is D. And now emergency management. In the ER, what do we try to correct? Except the odd man out, we have to shock, we correct. Hypoglycemia, we correct. Dehydration, we correct. Severe anemia means less than 4, we will have to correct. But micronutrient deficiency can wait. So the answer is E. Then aim of rehabilitation phase in the treatment of malnutrition. So we have the initiation, then the stabilization, initiation, and rehabilitation. So this is perhaps the 3rd phase. So what the aim is to repair cellular function, correct fluid electrolyte balance, restore homeostasis, catch up growth, and prevent death. All except catch up growth has already been addressed in the stabilization and in the initial phases. So the answer is D. So in the rehabilitation phase, our primary aim is catch up growth, and it has been said that we have to achieve above -2 Z score or that is 90%, almost 90% of the trough weight of the child, the lowest weight.
Thank you, Dr. Elizabeth, for that. Now, Dr. Praveen, the next 3.
Yeah, so I think this question, most of the people, they have responded, and the answer is correct. And although we see this hypophosphatemia, hypokalemia, hypomagnesemia, but the hallmark of refeeding syndrome is hypophosphatemia. So the correct answer is E. So serum phosphate level, as it's mentioned, we have less, then it produces weakness and other also neutrophil dysfunction, cardiorespiratory failure, arrhythmia, seizures. So all these are related to hypophosphatemia. Next. And the next question is also related to refeeding syndrome. And already Dr. Sija in her presentation has highlighted that thrombocytopenia is again one of the related to hypophosphatemia. So here again, the correct answer is A, hypophosphatemia, which causes leukocyte dysfunction, hemolysis, and thrombocytopenia. And then regarding this vitamin A supplementation in SAM child, already I responded to one of the query. All SAM children, if they have vitamin A deficiency sign, then they need 3 doses of mega dose vitamin A. If you have to give, then you have to give 3 doses. And children less than 6 months, again 50,000 is the correct answer. All SAM children should receive 1 dose of vitamin E unless they have received during last month. This is also correct. And vitamin E dose should be delayed till edema subside unless child has signs of vitamin A deficiency. This is also correct, which we discussed. So the last one is 18 months weighing 6 kg. If the weight is less than 8 kg, you remember we give half dose, that is 1 lakh, not 2 lakhs. So the correct answer for this question is E, 7E.
Thank you, Dr. Praveen. Dr. Sija, the next last 3.
Okay, features of kwashiorkor include all except. So diagnosis of dehydration is mainly based on history of watery stools and decreased urine output, right? Serum amylase, esterase, choline esterase, lipase, and alkaline phosphatase will be elevated. That is wrong because these are enzymes, and enzymes, as we all know, are protein, and usually the enzymes will be low. So that is the except answer here is B. Pneumonia may be identified only by X-ray. It can happen that you have a pneumonia, and because the baby is so weak, the baby will not have signs of pneumonia like a fast breathing or a fever. So that is also right. Urine microscopy and culture are required to diagnose commonly associated UTA. They are one of the hidden infections which may not have symptoms and signs, but you may pick up an infection by looking for microscopy and culture. And ECG changes may be there because hypokalemia is common in kwashiorkor, and these are the ECG changes of hypokalemia that has been described. So the answer here is B. Then points to remember while initiating feeds for a child with SAM are all true except only feed child with SAM in appropriate feeding position and supervise. That is important because the chance deglutition may be compromised, there may be muscle weakness, and the chance of aspiration is there. That is why feeding position is important and supervision is important. Caregiver should never eat his food in front of the SAM baby. The reason here is that for children with SAM, the salt has to be restricted, and adult food are usually salt rich, and you don't want the baby to crave for a salt rich food. That is the reason why it's written that should not be we should not take food in front of a SAM baby. For all cases, initiate feed at 130 ml per kg per day. That is wrong because kwashiorkor you're going to give only at 100 ml per kg per day. Breastfed children should always suckle before the diet and on demand. We know that because we want the baby to take as much of breastfeed as possible and not the formula. That is why you always want to pre-breastfeed and then give the formula. Then sufficient intake is defined as more than 80% of the prescribed diet. Okay, that is the right, because whatever you have prescribed, if at least 80% is taken, you can take it as a successful feed. So here the answer would be C. Next. All of the following are correct about identification of children with severe acute malnutrition except length should be measured if child is less than 2 years of old. Yes, we all know we take a length and not the height. And a 3-year-old child who's unable to stand, 0.7 centimeter is added to the measured length to convert it to the height to calculate the weight for height. No. In fact, when the child stands up, it's the other way around. So you have to subtract 0.7 centimeter. That is the answer for this question. And for an infant with length of less than 45 centimeter, visible severe wasting is used to identify SAM in infants in place of weight for length less than third standard deviation. That has already been elaborated by Dr. Praveen, and that's the right answer. Bilateral pitting edema without a known cause is an independent criteria to identify SAM in both 6 months and more than 6 months, irrespective of other anthropometric measurements. That is right. MUAC of less than 11.5 centimeter is an independent criteria for identification of SAM. So here the answer would be B. I think with that we conclude the quiz.
Thank you so much. Who's the winner, Pramod? Pramod?
Yes, sir. Savita
SAT.
is from
Savita has, can you tell who you are on the chat box?
I think she has been a previous winner also, I think.
I think she's a regular winner.
Regular winner, I
Savita,
think.
unmute yourself, Savita.
Savita, please unmute. So yeah, she's from.
Yeah, she's a PG
SAT.
from SAT.
Yeah, she's won once before. Yeah.
Yes,
Savita,
sir.
and there's one
From
Arvind.
SAT.
Yeah. Congratulations, Savita. Again and again, you're hitting a jackpot.
Thank you, sir.
That's very good. All the very best.
Consistent
Yeah.
performance, no? Consistent performance.
Yeah. Normally, she and one Arvind from Chennai are the competitors. So usually they come first and second. Very good. Congratulations. So we are coming to the end of this lovely session by Dr. Elizabeth. Thank you, Dr. Praveen Kumar and Dr. Shija. I now invite Dr. Pramod to say the vote of thanks.
Thank you all for participating in this wonderful session on SAM. And I hope everybody enjoyed the session. And I thank all the faculty and all the participants for the wonderful contribution, and congratulate the winner of the quiz. So I say good night.
Good
And,
night. Yeah.
good night, everybody.
Thank you so much. It is, yeah. Pramod?
Shall I end the meeting?
Yeah.
Yeah, thank you very much.
Thank you very
sir.
much, Dr. Praveen, Dr.
Yeah, thank you, sir.
Dr.
Thank you for the opportunity.
Fantastic. It was very good. Excellent sessions. Thank you. I hope the PGs learned a lot from this. Bye. Keep in touch.
Okay, good night, sir.